Welcome to the Sniff Spotlight Series, your one-stop shop to find out what's really going on in sniffs nationwide. I'm your host, Yitz Rubin, and this is sponsored by Renewal Rehab, the best therapy provider for sniffs nationwide. Welcome to the Sniff Spotlight Series. Today's guests are Mr. Dov Belsky and Phil Rzepka. Dov is the clinical coordinator at Presque Isle Medical Technologies, and Phil is the marketing liaison. They specialize in mobile prosthetics. Dov and Phil, thank you so much for being here today.
Thanks for having us, Yitz.
Yitz, thanks for having us. Appreciate it.
Dov, what made you get into prosthetics?
I wouldn't have chosen prosthetics. I actually married into the family. My father-in-law is a second generation, so I guess that makes me third generation in the prosthetics business. And we're a family-owned company, and it was just natural to join the family company.
Phil, you recently joined Dov Belsky's family and joined this company. What made you want to be a part of this organization?
What made me want to be part of this organization is my background in physical therapy. So I went to school for physical therapy. I really enjoy helping others and watching them succeed. So prosthetics was a big step in my career personally. I really like the fact that we're basically helping people walk again. So that's kind of a big deal breaker for me.
Can you tell me the difference about what orthotics and prosthetics are?
Prosthetics is a replacement of a limb, and orthotic is more of a stabilization of a limb. So if you need to stabilize a joint or a body part, that's an orthotic. When you need to replace a body part, that's a prosthetic.
What are the leading causes for amputation?
I would say nowadays around 80% of most amputations are secondary diabetes. Well, diabetes is the main cause, and that just snowballs, patient not take care of themselves. Ultimately, the main thing that actually causes the amputation is an ulcer that gets infected, turns gangrenous, and then leads to amputation.
80%?
80% diabetic amputations.
Wow. So from those patients that need this, what would you say the psychological effects that this would cause?
It can be devastating psychologically on a patient. Here they were a whole person, and now they're in their eyes an invalid. They're half human almost. So those first couple of weeks post amputation can be very challenging on the patient, and it sort of affects the prosthesis, because if they don't care for the prosthesis, they don't think they're able to achieve mobility again, they're never going to do it, just purely from a psychological aspect of it. The first step in getting a prosthesis is getting over that hurdle, that denial, or that mindset that they're an invalid and they're not capable of doing something anymore.
So Phil, your role in this, going to facilities, finding those patients that might need those prosthetics.
Correct.
How would you approach it, and how do you find whether someone is eligible for a prosthetic?
So our prosthetist actually determines that. So the process is actually, once we get a referral from a facility, our prosthetist goes into the facility, evaluates the patient, and works with the therapist to determine what's best for the patient. We also work with physiatrists that normally would write us a prosthetic order, which means basically they're cleared for a prosthetic. So at that point, we know that they're capable and have the strength to stand up once they start using a prosthetic.
Wouldn't it be something that a hospital will typically deal with and not necessarily a nursing home?
The hospital doesn't cover for it, and the nursing home doesn't cover for it. So ultimately it's covered for insurance. And it's usually the length of the process is by the time they're actually ready for the prosthesis, they're out of the hospital. They're sometimes even out of the nursing home, back home. But a lot of times it's far enough out where the hospital, they might start the process, get a shrinker on a patient to help start shaping the limb. But the actual, when the patient's ready for the prosthesis, is usually a few months down the road from the amputation. So it's typically going to happen either in the nursing home or once the patient goes home.
So this is done through a mobile system? You guys specialize in mobile prosthetics?
Yeah, so a few years ago, it first started off as more, why have the patient come to us? They're an amputee, it's hard enough as is for the facility to arrange a ride, a special car to get them there. So we figured, hey, let's just offer the service, we'll come to you on site, you don't have to worry about getting the patients to us. And that quickly morphed into realizing that they're a very niche population in the nursing home, amputees. So most people don't know what to do with an amputee. So therapists don't deal with them on a daily basis. The nurses don't deal with amputees on a daily basis. And that really leads to a lack of care just by default, because no one really knows what to do with an amputee. So we realized once we were actually going to the nursing homes that the level of care the patients were getting was actually getting better due to the fact that we were seeing them at the facility. And it turned from just delivering a prosthesis to more helping therapy out when they see the patients, helping the nursing staff out, restorative out, letting them know what to do with their prosthesis. Until now was they came to our office, they'd come back with a prosthesis, and no one knew what to do. And then we'd be like, oh, hurts the patient, doesn't like a prosthesis, they don't want to walk. When in reality, it was just hurting, it wasn't fitting right, and a small change might actually make them go from sitting in a wheelchair to up and walking. So doing that at the facility with the whole team enabled the patients to get better care, and ultimately that just benefited everyone.
And going back to the psychological standpoint, when a patient goes home, they kind of feel like they can't really do anything on their own anymore, so there's a lot of neglect. So that's kind of when we come in and we kind of help them going. We work with therapy, make sure that there's a therapist at the house, and our prosthetist is there to show the therapist how to put the prosthetic on, use the prosthesis, and help that patient moving again. So that's kind of the whole point of mobile as well, because without us being mobile, that patient a lot of the time will not even reach out for a prosthetic limb.
It's very good. They can come to the office, everything's clean, everything's perfect, the steps are perfect, they can walk up the steps. When they go home, stairs a little rickety, stairs a little broken, carpet's in the way, and a lot of those barriers that they face on a daily basis are not seen in the office. So actually seeing them at their house, at the facility where they're actually going to be using the prosthesis, we can make sure to foresee any problems that might arise and hopefully fix those.
From the beginning stage of when you guys decide, or when the doctors decide, hey, this patient is going to need a prosthetic, like how does that work? And when they get it, how long does that take to actually recover and get used to that?
The ultimate goal is the sooner we see them, the better for the patient. A lot of times, therapists, the doctor, like, oh, the patient's not ready, and they hold off calling a prosthetic company, which is going back to the whole on-site, seeing them there. If they only sent the patients to the office, it'd be when they're actually ready for the prosthesis. That's when they get sent out. Whereas here, we come to them, we can go much earlier. We can see them closer to the amputation, so we can be more on top of when the limb heals. Some patients, due to the fact that it is a diabetic dysvascular amputation, it takes longer to heal. The sooner we see them, ultimately the end result, it helps the end result, it is better. Once we see the patient, it's just waiting for that limb to heal. Once that limb heals, we can start the casting process. It's a fairly quick week to 2 weeks from when they get cast to actually getting the prosthesis, and that's really when the journey starts. The journey doesn't start when they get when they get the prosthesis, it starts when they get the prosthesis. Until now, what was happening is, since they're a niche population in the nursing home, they're almost a forgotten people. They would come back with the prosthesis, and then that would be the end of it. And then they might use it, might not use it. Whereas here we see them at the facility, we're constantly being called back, and it's really just the start of the relationship, where once a week, twice a week, or until they actually get comfortable with actually using it. And then it's every few months seeing them.
Yeah, it really depends on the situation and how well the patient's healing. And once we get clearance from wound care, basically, because a wound can take 3 months to a year. Maybe there's a reinfection sometimes. So sometimes we can start a process and, that patient might not be ready for another year. But some patients heal very quickly, and we can, cast the patient. And once we cast the patient, we 3D print our sockets. So once our sockets are printed, they're shipped out within a week, and that patient's hopefully walking.
Wow. So this is all done 3D. First of all, that's a super cool,
Yeah.
Getting a little...
The industry is getting there. I would say we're on the forefront of the industry. Now we're from the early adopters of 3D printing and 3D scanning. There's some fear, I would say, in the industry, like, oh my gosh, technology is replacing our jobs. Whereas that's not really happening. It's process still needed. It's just another facet of it can be automated. Until now, it was, if there was an issue with the socket that something couldn't be fixed on site or anything, we'd have to take the prosthesis back, re-pour it with plaster, remake the socket, with all the changes. Whereas now, since we have that first socket 3D scanned, we can make changes in the computer and just print it an hour later, send out the socket, and the patient could be up and walking again fairly quickly. So it speeds up everything. Instead of 1 to 2 weeks, it could be 1 to 2 days.
So you guys, from what I understand, you guys are in from the beginning, from at the time when this patient gets the diagnosis that they need to be an amputee. You guys would typically want to be there before to be able to work with the doctors and say, hey, let's do it this way so that we can create this prosthetic.
Correct. There are some surgeons, depending on the way they amputate, can make the process a little more difficult from our end. Again, we're not the surgeons, so ball's in their court. But the sooner we talk to the patient, a lot of it's more from the psychological, mental aspect of it, them knowing that, oh my gosh, I'm about to lose a limb, world's coming to an end. Whereas we can walk in there and say, don't worry, the only difference between me and you is I wake up, put my pants on, and go out. You put your leg on, put your pants on, and then go out. So it doesn't have to be where you're stuck in a wheelchair and life comes to an end. The possibilities are endless. So the sooner we get to the patient, the sooner we can start communicating that to them, and the sooner we can show them what a prosthetic is.
There's so many different prosthetics with technology coming out. Would you say that a lot of what you do has capabilities of getting a person basically back to their normal functioning level?
Yes, I would say the patient has a very good chance of getting back to being fully functional as long as the therapy starts as soon as possible. Without therapy, the patient's going to just decrease in functionability. So I think it's really important for the therapy to actually start with the patient right away and start strengthening their weaknesses and their opposite leg. So they need to start balancing out strength and working with the patient to get back up on his feet as soon as possible.
The prosthesis is not a magic wand. You'd be surprised how quick the body forgets how to walk. So we can pop on a prosthesis, but they just don't remember how to walk. And that therapy is a crucial aspect of the overall process. We're just one piece of the pie. It's really a team effort between us, the prosthetist, the therapist, and the doctor, making sure that patient get up again and walking. A lot of times the patients will be like, oh, I have a prosthesis, why aren't I walking? Like, it should just propel me up and let me walk. Whereas it's not a simple process. You have to be motivated to do it, but if you have that motivation and that will, you can do it. The technology out there is so amazing that you can get back. There are Olympians that are amputees, so you can for sure get back to your prior functioning level if you want to. Not everyone can due to certain medical conditions and all that, but if there's a will, a lot of times there is a way to get back to what they were doing prior to amputation.
Have you seen any particular stories which was like, this was fascinating that you guys were involved in?
You see humanity, raw emotions of humanity. Whereas we had a patient deliver the first prosthesis. Therapy wasn't comfortable with him walking in his room by himself yet, but he was like, I just want the prosthesis. I just want to sleep with it tonight. And that night they saw him snuggling with his prosthesis like a teddy bear. It's a raw emotional thing. Seeing someone walk again for the first time, sometime after, could be a couple months, but sometimes after 3-4 years they haven't walked. And getting up from that chair and rediscovering their independence is it's an inspiring thing.
That must be amazing, especially you, Phil, outside in the field. Do you ever get emotional, like seeing that?
I try not to kind of think about it that way. Like this patient had a burden on his life, but I just mostly think of the positive outcome and wow, this guy's going to be able to walk, or she stood up for the first time by herself in 2 years, like Dov said. Sometimes the patient's in a wheelchair, hasn't had a prosthesis ever. The amputation was 6 years ago and they finally got around to it, and this patient's life's changed completely. So yeah, it's a little emotional. I feel a little emotional talking about it right now, but yeah.
What do you wish owners and operators and clinical directors in nursing homes would know about what you guys do and how you can help them?
A lot of times the barrier is they're used to orthotics. Orthotics are not covered by insurance in a nursing home stay. So a lot of times they confuse orthotics and prosthetics, and they'll wait till the patients finish their skilled stay, because prosthetics are not cheap. They're An orthotic might be a couple $100. A prosthetic can be several $1,000s. It's all covered by insurance, even on a skilled stay. So just them getting over that fear of like, oh my gosh, if I call in the prosthetic company, we're going to be charged a hefty amount. And that fear a lot of times prevents them from calling us in and waiting until the patient's towards the end of their stay to call us in. Whereas just to know is that everything's covered by insurance. And the sooner you call us in, the better care the patient's going to get ultimately.
And that's actually, it's like a separate allocation of funds as well. So it's like if some people are like, oh, it's going to be taking out of like their Medicare, it's really not.
It's all covered by insurance.
By Med B.
By Med B.
Correct.
Even on a Part A stay. If they need a prosthetic, insurance will cover for it. And if there's any issues with the prosthetic, insurance will cover for any fixes and all that also. Yeah. So a lot of times they'll be like, they have a prosthesis, doesn't fit them, they can't wear it. And like, oh, they got it 2 years ago, so it's too scared to call them. We'll, insurance will cover something new. They understand that the body's constantly changing, and as such, the prosthesis that fit 6 months ago might not fit today. And the patient needs something new in order to keep them walking. Because ultimately, the more they get them out of the chair, the better it is for the patient. Having someone stuck in a wheelchair sitting the whole day is not great for their health.
Yeah, I mean, this is something that actually seems to really help operators, the patients, families. This is something that could really keep people healthy. With you and your background, Phil, have you been involved in being a therapist for someone who had this prosthetic?
I personally have not, but since I'm out in the field, I do go into the therapy gyms at some of the SNFs, and I'm there with the DOR, and sometimes I'll watch the patient being worked on. So some of the other barriers we're having right now during a pandemic is having access to the facilities and seeing the patients. And like I mentioned before, the patients need to be seen right away, right? So the sooner we get to them, the better the outcome for the patient, the sooner they can get a prosthesis and start wearing that. With COVID, we have to schedule appointments. We need COVID testing done before we enter the facilities. Some of the administrators are a little bit more lenient, and some of them are a little more hesitant with us coming into the facilities, so it just really depends.
That seems like a common issue that many caregivers for nursing homes are having now with coming into COVID. How do you get in? But I think things are easing up now.
Things are easing up. We're seeing a lot, interestingly enough, that if the breakdown of amputees, typically you're below knees, you're more common than you're above knee. It's they try to save as much of the limb as possible without going too high. The higher you go up, the odds of dying increases. So with COVID, we feel like there's a lot of patients just not getting the appropriate care early enough, not being seen by the surgeons early enough. And by the time, we're seeing a lot more above knee amputations now.
So what's the difference between general prosthetics and advanced prosthetics?
If you boil down a prosthetic, the only thing custom is what attaches to the stump, to the residual limb. Everything else is, in a sense, off the shelf. The most important thing is the fit of the prosthetic. You can have the greatest technology attached to that prosthetic. If it doesn't fit properly on the patient, is really a paperweight. Some of the technology on the knees, you can have computerized knees that can sense if the patient's falling. It can sense different barriers, the level of the ground, and adjust some of the resistance of the knee. Same with the ankle.
Which is the microprocessor.
Microprocessor.
So that's kind of the...
Yeah, the creme de la creme of the prosthetics. But the funny thing is, the more advanced the patient is, the less they really need that advanced technology.
That's true. The
human body itself is the greatest of everything. So the more stable they are, the more secure they are in walking, the less they need to do well. So the microprocessor need, which is really the paradox where insurance only wants to cover the high-end stuff for the better patient, the quote-unquote better patients, the ones that will use it more, whereas it's the lower-end patients that really need that higher technology to prevent them from falling. So there's that cost analysis that insurance is notorious for doing. They decide that, well, if you're stuck in the wheelchair, you're not going to fall. You're not going to fall, you don't end up in the hospital. So insurance doesn't really want to pay for the higher stuff unless your risk of falling is less.
Right. So that's a little bit of the dark side that we were talking about.
Well, there's some, that's the dark side. The insurance aspect of it is the dark side. And then you always have the various, since they're a forgotten niche population in the nursing home, the patients are very easily taken advantage of because no one really knows, is there an issue with the prosthesis or is it an issue with the patient? Sometimes there's nothing wrong with the prosthesis, the patient's not capable, or there's something internal medically with the patient. Whereas there are companies out there that almost in a sense prey on the unfortunate nursing home patients. They can come in there, drop off a prosthesis, and then always blame everything on the patient. Oh, nothing wrong with the prosthesis, there's something wrong with the patient. You just got to give it time. It might hurt today, but that's just got to get used to the prosthesis. And no one really knows if that's true or not true, because no one really knows anything about prosthetics. That's another thing we've seen going into the nursing homes. We can help the therapists and the team on site know whether, hey, there's something wrong with the prosthesis, nothing wrong with the patient. You just get them in a proper fitting socket and everything will work itself out.
What kind of obstacles do you guys come across with medical cover?
One of the main obstacles we face is documentation. Nowadays, if it's not documented, it doesn't exist. So one of the ways insurance tries to prevent fraud is by taking documentation out of our hands and putting it into the doctor's hands or the therapist's hands. So the patient might be appropriate, they might be ready, but if we don't have doctor's notes stating that they're capable to use the prosthesis, they're medically fit to use the prosthesis, insurance won't cover for that. And that's something where it's the doctor or the therapist has to do that. So we can harass them, we can annoy them, but if they didn't do it yet, there's nothing we can do to actually get the prosthesis. And a lot of times that does fall on our shoulders. We're the face of the prosthetic, so of the prosthesis, and the patient gets angry at us, like, where's my prosthesis? And the last thing we could do is, throw the nursing home under the bus or throw the doctor under the bus. So it's more trying to balance getting the documentation in a timely fashion with providing care for the patient at the same time.
It delays the patient's ability to start working quicker with the prosthetics. Sometimes if, the DOR, the director of rehab, or the physiatrist or NP, they haven't done any notes. So we can't really, sometimes we have the prosthetic with us ready to be delivered, but we can't deliver it yet, because if we deliver it and there's no documentation for us, we're basically giving away free products, and we're taking the hit on that. It's important for the therapist and the physiatrist, whoever's signing the documentation, to be on time and timely with that, because it's not just delaying. We don't mind really, but the patient might mind, and we want the patient to be happy. So yeah.
Tell me a little bit about double amputees.
So double amputees, everything gets harder, but it's not impossible. There's different on the heart, how much it taxes the heart walking with the prosthesis. So below knee will tax the heart X amount, and above knee will go even more, and a bilateral really makes it difficult. So it's not impossible. It increases the difficulty in everything. A lot of times where we might even just do one prosthesis for them just so they can get up and transfer some more independence, go from their bed to the wheelchair. On a bilateral above knee, a lot of times the barrier is just stability, where the first thing is get them on what we call stubbies, 2 prosthetics with no knees, just feet, so they're very low to the ground. So if they fall, their hands are a couple inches from the ground, so they can use their hands almost as like crutches, and that gets them used to balancing, walking around. And then hopefully if they progress, we can pop them some knees and then try.
Yeah, and we've actually recently had a bilateral amputee that was a very young patient. He was just 21 years old. I think it was a gunshot
wound,
victim.
Yeah, complications of a gunshot wound.
So he had a bilateral amputation. But
so part of the issues, that's another issue we run into, is on a bilateral, a lot of times the better technology is better for them. So if you're bilateral above knee, you want the microprocessor knees, but not all insurances cover that. So Medicare will cover for that, Medicaid won't cover for that. So sometimes our hands are tied in what we can give the patient just based on the insurance.
Thank you guys so much for giving us such an in-depth about amputees and prosthetics and SNFs.
Yeah, thank you.
Yeah, thank you for joining the SNF Spotlight. I really
Of course, yeah, it was a good time. Thanks for having us.
Thank you for sharing this tremendously important part of senior care. The SNF Spotlight series highlights healthcare heroes and thought leaders in the skilled nursing community. We're building awareness, trust, and shining the light on SNFs. So stay tuned. Remember to like, comment, and share.